Koutou e hui hui tahi nei I te whakarewatia tēnei kaupapa whakahirihire. Nō reira, tēnā koutou. Me tīmata I te karakia, kia tau te manaakitanga, ki runga, ki tēnā o tātou. Kia piki te ora, kia piki te māramatanga, kia hoki pai atu, kia hoki pai mai, tūturu whakamaua, kia tīna, haumie, huie, tākie.
Okay.
Welcome everybody to this hui, and I'm now going to hand over to Susan, who will introduce our speakers and the agenda for the day. Kia ora.
Kia ora, Teresa. Tēnā koutou katoa, ko G te whānau, ko Susan toko ingoa. I'm Susan G. A very warm welcome to you all for what's going to be a cracker for our last hui for 2025. And we've got three outstanding experts who are each going to share their expertise on a different angle of things we know can work to help improve cognitive functioning in dementia Māori Wareware. So if you have questions along the way, please do put them into the chat and we'll gather them out of the chat to share them with our speakers. So our first speaker today is Professor Yun-Hee Jeon, and Yun-Hee is the Professor of Health and Ageing at the University of Sydney, where she runs the Dementia Rehabilitation Lab. And Yun-Hee is, besides being lovely, absolutely amazing. So Yun-Hee was the co-author of the 2025 World Alzheimer's Report on rehabilitation. She has led world first trials on cognitive rehabilitation, and get this, Yun-Hee has published over 190 academic papers. So we are just thrilled to have you with us today, Yun-Hee. So she is going to be sharing her insights about embedding cognitive rehabilitation within interdisciplinary dementia rehabilitation models.
Oh, thank you, Susan, for the amazing introduction. It's always a bit embarrassing too when someone introduces you to about what you've done. Now, I'm just absolutely privileged to be here today and to talk to our neighbors. And I've been living in Australia for over 30 years. I'm from South Korea. And I think, I had my PhD supervisors from New Zealand. And I've been to New Zealand a few times, so I feel very close to where you are. Now, today I'm going to talk about cognitive rehabilitation in the context of the interdisciplinary rehabilitation, dementia rehabilitation framework. And I want to go a bit of unpacking of what cognitive rehabilitation is, what dementia rehabilitation we're talking about. And I'm very pleased to have the next speaker is going to talk about cognitive stimulation therapy. The terms that people sometimes get confused or, have some different understanding. So let me just share my screen first, and you're going to see my Wareware first, but I will quickly transition to my slide. So now, before I begin my talk, I'd like to acknowledge the traditional custodians of the lands, the Gadigal people of the Eora Nation, on which I'm presenting today. I pay my respect to their elders past, present, and emerging generations. And so before I talk about cognitive rehabilitation specifically, but I thought I'd just give you an overall picture of rehabilitation is not unique to dementia, right? And we have a range of different understanding about the rehabilitation, and we hear about reablement and restorative care. But at the core of this concept is that the rehabilitation is a collaborative journey. It's a partnership between the person, the practitioner or rehabilitation team, and others such as family members or care staff. It's all about working together and making choices and doing with the person rather than doing for or doing to the person. So what we say in our World Alzheimer Report is it's a practical demonstration of everyday of how to put the person-centered principles into practice to support the person's day-to-day functioning in a fully personalized approach. So those core concepts are personalized. It's also goal-oriented. Often people don't recognize the importance of this goal-oriented, but that is actually part of the rehab, and it's collaborative. So I think when Linda Clare and I were, commissioned by the Alzheimer's Disease International, we were absolutely thrilled, about this opportunity, and we spent quite a lot of time thinking through how best we could actually unpack this dementia rehabilitation in the context of post-diagnostic dementia care. And so I think the Matthew has kindly asked me to talk about the report itself briefly towards the end of my talk. But it is designed to really help people. It's not designed for researchers, but it's designed for people living with dementia, those who are affected by the condition, the families and friends and others, as well as practitioners who are providing the care. So we want to make sure the report is written in a way that is really easy to understand and accessible to everybody. And we hope that we've done what we plan to do. Whenever I think about rehabilitation, and this is the kind of my go-to diagram, because I find this extremely helpful to explain what we mean by what we do and how we do in rehabilitation, which is very closely aligned with the concept of healthy aging. And it is often about the person, individual, and their environmental fit. So if you look at the healthy aging concept, and it's a constant journey. It's not just a status; it's a process, right? And so this diagram really shows that the ones in the red square in the middle is the person, and then that's the environment. And you can see that this is a really, it's a plural. It's not just a physical environment. It could be climate, it could be social environments and other people environments. And so this is where this blue box here is about individuals' functional ability. And this is how we try to do our work through rehabilitation. But what it is really importantly, we have to take this individual's intrinsic capacity into account. And so we talk about functional ability. So rehabilitation is about improving functioning, and these are about moving around, building and maintaining relationships, meeting individuals' basic needs, learning, growing, making decisions, and contributing. So these are actually functional ability we are talking about. So when we talk about dementia rehabilitation, it involves all of them. And when you then turn that ability into individuals' day-to-day life, these are the things, our day-to-day work, our communication, our relationships, moving around, playing, doing self-care, all these things. So what we try to do is that we work with the person and their families and others to help them improve their independence by addressing those functioning. And I'm going to start with some of our trials that we started, and I'm still currently conducting the trial using the concept of rehabilitation and how we incorporate cognitive rehabilitation. So in 2014, I started this journey, having conversations with my colleagues in the US. So Johns Hopkins and Sarah Zenton, she is now the Dean of School of Nursing at Johns Hopkins in Baltimore. And she started a program called Capable, which was designed for people, older people, often socioeconomically disadvantaged, living at home with complex chronic conditions. And then they created this capable model consisting of an occupational therapist, a registered nurse, and then they call handyman, and they really work together to provide the comprehensive set of care. And they use this concept of a person environment fit, and the working, the practitioners work together to actually help those older people to improve day-to-day function. And I was fascinated by that model, but what they did and their program excludes people with anyone with cognitive impairment. So I really like the model, but I wanted to then make an adaptation of that model for people living with dementia. And so that's how our journey started. And so we did a pilot study working with the nurse and the OT. And so we initially spent some time with our US collaborators to understand how they actually offer their program. But we want to make sure that this time we actually include aspects of care that could actually help people with dementia. So that's when we introduced the concept of cognitive rehabilitation. So cognitive rehabilitation, it's a therapeutic approach designed to help people improve or compensate for problems with thinking skills such as memory, attention, problem solving, or planning, often after brain injury, stroke, or diagnosis of dementia. So it's not actually unique to dementia. So cognitive rehabilitation has been around for some time. And but it's not about improving cognition as the goal of the cognitive rehabilitation. So it addresses individuals, their lost or new information, lost or new skills. So it's addressing the individual's ability to deal with the information and day-to-day skills so that they could actually act more independently. And they use various techniques, and they often under two umbrellas. It's restorative techniques or compensatory techniques. And so what we try to do is to really use those techniques to help people to function, improve their function and maintain their function. So often cognitive rehabilitation isn't necessarily designed to improve cognition. So this is the part that is distinct from other cognitive therapeutic approaches. So what we did was we incorporated these, techniques as a part of our package of intervention. And as you can see from here that we have a program logic. And so I-HARP is the name that we created because it wasn't just multidisciplines of practitioners. it's actually interdisciplinary. They share common goals of the person they provide care, and then there are aspects of the care they offer. It could be done by the nurse one day and the OT on another day. And so I'll see if I can explain a bit if I have the time. But so as you can see from this box of the components of I-HARP, you can see that there is comprehensive assessment. There is also the home modifications or providing some assistive devices. They also encourage and work with the person use of compensatory strategies, medication reviews, strength and balance training, problem solving, pain management, and cognitive rehabilitation, carer support, and referrals. So it's you can see that it's a kind of a package of approaches that address the person's needs. Now, what we are trying to do here is that it's on the premise that when people have dementia, they don't just have dementia. They have other comorbidities. And often they interconnected in the way the person lives their day-to-day life. So, for example, the person may have a difficulty with their memory, but then their recall ability is very limited. And then on top of that, then they have to take multiple medications. So if the person doesn't have to take medication, that's less of an issue. But then the person takes medication for various reasons. We know older people have, over 80% of them have multimorbidities, and they often have polypharmacies, more than 5 medications. And so when we, provide rehabilitation and work with the people living with dementia, we can't just think about dementia itself. So this is how both Capable and I-HARP try to address older people have complex care needs. How do we actually incorporate this in the way that we provide care that is more seamless and integrated? So, the principles, the I-HARP elements, the way that it's designed based on these various theories or frameworks that underpin the overall process. And at the end of the day, we want to make sure that we address both intrinsic and extrinsic capacity, so that environmental as well as individuals. It could involve the personality, how you work with the individuals who's been living that way, a long time for their life. And then we look at how they fit in their environment, and then we try to address the ultimate goal of improving quality of life. And I guess what we really want to make sure is that the person is actually having more sense of purpose in their day-to-day life. So when we deliver our I-HARP, this is a kind of, the image that we have come up with. So basically, we have these 6 occupational therapist home visits, and then we have 4 registered nurses home visit, and then we have 3 carer sessions. So when we deliver the rehab program, it isn't just about one practitioner providing that approach, therapeutic approach. It's actually working as a team. And the team involves carer, care partner, working together. So when we train nurses and OTs, we train them together, and then they both understand how they actually use cognitive rehabilitation principles in the way they assess the person and the way they set goals with the client. So this is conducted over 4 to 6 months, and that's how we did our program. And as you can see that we have used various types of environmental assistive devices, sometimes installing a grabber or a railing so that the person is able to actually walk more independently, not having to rely on the member of the family all the time. And it could be just simple, talking clock, or the clock that is more, easy to read. So this is something that we have done through our I-HARP trial. And I just want to emphasize that we want to make sure that family members, so we chose one primary carer, and then we help them understand what rehabilitation is, because practitioners are there only for an hour and 1.5 hours each time. The rest of the time, whatever the goals that they set with the person and the family, they need to be, implemented with the support of the family carer. And of course, the kind of limitation of our program is we chose the diets rather than just a person living with dementia. So we didn't include the person if they did not have a primary carer. But the way that we look at it is, if they had a care worker visiting home, they could be part of the team working together. So we had to spend quite a lot of time working with the family, helping them understand what we mean by reablement and rehabilitation, because families often, with all good intentions, they want to do things for them. They even speak on behalf of the person, even the person is sitting next to them. It has become a kind of habit for some people. So we want to make sure that our practitioners are trained to make sure that when they visit home, they always address the person first, and they are the center of the attention. So to do that, we had to make sure that we have additional sessions with the family carers, why we are doing it. And when, the person, the occupational therapist assesses the person, that makes sure that questions always directed to the person with dementia. So I think that these are the things that we want to make sure that we do in our trial. And I thought I'd just share a very brief case of one of the participants. Mr. Jones, he is, 79-year-old. He had mixed dementia, and he was quite fit, reasonably fit. He had some cardiac problem. He had bilateral cataract. Somewhat unsteady, but his physique was a fit person. He had some hearing difficulty and possible depression. So he had no major activities of daily living difficulties, but he likes walking, but he was unable to find a walking group he likes to join. He often forgets bum bag he carries, and then mobile phone when goes out for a walk. So these are the things that we actually go through when the nurse and OT conducts initial assessment. We spend quite a lot of time. So for OT, they take about 2 hours. It takes 2 sessions to assess the person and also their home environment. For registered nurse, it takes 1 session. So they go through the whole process of comprehensive assessment, and then they, go through. Then we have the case conference, and they also make sure that they understand whether there is any care issue. And so I think that's the background information they use. And then when they visit after the assessment session, they start exploring what kind of goals. Now, often when you talk to the person, about goals, they don't come up with a goal. We hear about SMART goals. The goal has to be specific, measurable, and so on. No one comes up with that goal straight away. So often the nurse and the OT make sure that, when they have done the assessment during their case conference, they try to unpack what are the potential goals for the person. And then when they visit next time, they then float around those potential goals if the person can't come up with their own goals. So sometimes people say, this is what I really want to do. And the goals, often it's not always in the form of I want to do something. It's often to do with I'm really having difficulty with something. And so between those two, what I want to do or what I having difficulty, then they discuss what kind of things that they could work on. So I think for Mr. Jones, and he really wanted to be able to go for a walk more frequently, and he's wanted to improve his strength and balance. He doesn't say that I want to improve my strength and balance, but what he say is that, I want to be able to go for a walk more often, and I want to join this walking group and so on. But then what is it that is actually stopping him from doing things? So I think then, the OT and the nurse sit down, and then they go through things that they could actually work on. So what are the problems, they're stopping him from going for a walk? And I guess one of the things that, he's, remembering what kind of things that he needs to prepare, but also what else he wants to do. So if he wants to do, activities like doing, having lunch with his son, going for a walk, all these things that you actually use some form of compensatory aids. So it could be sometimes we use a whiteboard. Sometimes we use the post-it. Sometimes we recommend a diary. So these are the things that individuals want. They feel comfortable with, and then the clinicians work through together. And then they make sure that it is visible to the person when they have. So people have their favorite place for breakfast, and then near the breakfast table we make sure that there is the diary, or near the breakfast table there is a whiteboard. And then we go through the kind of practice of sometimes people use like an errorless learning process as part of cognitive rehabilitation techniques. Other times they use a particular, problem-solving techniques, and sometimes they use space retrieval strategies. So depending on the needs and the person's ability, they actually, adopt a particular strategy to unpack some of the issues that they may have. So, and in the meantime, the nurse will make sure that, that their medications are all in order. If they have any difficulties with, remembering certain things, that the nurse could to work with the person. Or if it falls into the OT's home visit session, then the OT works with the person. So there are a lot of overlaps between the OT and the RN during their home visits. And so the nurse may take responsibility of, we had a I-HARP specific strength and balance exercise, and then the care partner and the person are encouraged to practice it. And the OT could also work with the person that if because he likes to make Spanish omelets, and then the OT worked with him. What are the things, they break down the sequence, how that could actually be done, and then they practice with OT, and then until they become more confident. So these are the things that we it's just one snapshot of it, and given the time we have, I can't go details. But what you can see is that a lot of what we do is incorporated as a part of the home visits, and it's so those cognitive rehab techniques are embedded as a part of the personalized goals, rather than the practitioner goes to the person and then, here are the strategies, I want you to practice those things. So it's never that way. And individuals often have like 3 goals or 4 goals, but sometimes people may have 2 goals only. And the goals may change. Sometimes the person may have other unforeseen medical conditions. So you have to be really flexible and making sure that you monitor the progress. And when we, did our main trial involving 116 diets, and we were able to demonstrate that when people have mild dementia, we were able to demonstrate their independence could actually improve, and then the rate of decline could be a lot slower than the control group. So this is red line is the control group. And you can see this is a typical journey if you don't do any rehabilitation. Whereas this is when you implement rehabilitation, this is how your independence could be maintained. Unfortunately, when we look at the overall trial, we didn't actually see the actual improvement in dependence. It's only post-hoc analysis we were able to unpack it. What we found was when we offered dementia rehabilitation, later stage, moderate to severe, then it doesn't actually improve their independence. There could be other benefits, but then when it comes to independence, we were unable to demonstrate it. So this is now, so after our I-HARP trial, we have introduced the concept into care home environment. So we are just finalizing our final data collection. So we had to then, we work with 2 aged care service providers in Australia and working across 3 different states. So we have 16 care homes involved, and half of them are intervention, the other half control. And it's an implementation trial. So we are not necessarily trying to demonstrate it's effective or not. We are evaluating the actual program, but we want to learn how that implementation works. And so we had to modify the way that OT and the nurse works with each other. Now they are in the care home. There is the family carers are often not there, so we devised the ways to involve care workers and activity lifestyle coordinators and other allied health professionals. So this is how we are currently doing our I-HARP, I-CHARP model. And I guess it's very much the same. The core components of I-HARP still in this place. And what we really want to make sure is that it's interdisciplinary teamwork, and we have to actually make sure that we offer tools for them to work as an interdisciplinary team, and case conferences, and we provide protocols for them to refer to, how they communicate each other, and so on. So this is our program, and as I said, it's we are very proud that we have managed to come this far, because it's very it is challenging, because that's teamwork. When you are already a team, it's easy, but we are making this artificial team to work together. So we had to come up with a range of strategies to make sure that there is, so one of them is about clinical supervision for OTs and nurses. And then we have, communication strategies and so on. So these are the things that we've done for our I-HARP and I-CHARP. And what we want to, what I want to, emphasize is that these are just 2 different models, one in the home environment and the other in the care home environment. But rehabilitation comes in various shapes and forms. And when the person is, in the very early stage of dementia, they may not need multidisciplinary or interdisciplinary team approach. They may need a particular, it could be speech pathologist, it could be an occupational therapist, or it could be a physiotherapist. But as they progress, and then as depending on what other medical conditions have, then they are, better served by having multi and interdisciplinary teamwork. And we see this rehabilitation as a core element of post-diagnostic care and support. And this is what we try to show in our, the World Alzheimer Report. And we spent a bit of time trying to unpack, how, there are a lot of different understanding about, cognitive rehabilitation, cognitive training, and cognitive stimulation therapies. And often, the cognitive rehabilitation is considered as the same as others, but they are not. So we decided that, so when I say we, Linda, Claire, and I, we had weekly meetings, and sometimes twice a week. And then we decided how best we could actually, help people understand. And that is based on the principles of rehabilitation and why dementia rehabilitation is unique. There are a lot of other concepts in rehab that are shared with other rehabilitation, stroke, and others. But then there are some of the unique aspects. And so if you look at the first sections 1 and 2, this is very much around what it is, dementia rehabilitation, how cognitive rehabilitation is used. But what we try to do is that, in this definition of terminologies is in the report, we use rehabilitation, sometimes referred to as reablement, and cognitive rehabilitation somehow interchangeably throughout, because it's cognitive rehabilitation isn't about improving cognition. It is about this cognitive decline, addressing the cognitive decline to improve or maintain function in day-to-day life. And so that's what we, we worked on. And then in the report, that the section, 3 and 4, it's very much about implementation and how this dementia rehabilitation has been successfully implemented in some of the countries. And of course, we were not able to, give all the case examples, but we had 6 cases from Japan, South Korea, and Indonesia, and we even had Togo and Malta, and we had Brazil. And so I think these are the case studies. It's not because that they are the only countries doing it, but we want to make sure that it's across the globe. And what we learned was, dementia rehabilitation is offered extremely limited, even in high income countries, offered in ad hoc, and we want to make sure that is changed. And I want to just throw one other thing here, that some of you are aware that we have this World Health Organization's the package of interventions for dementia rehabilitation, and we have dementia specific chapter. And so these interventions, when we had these interventions listed, they're not necessarily on their own rehabilitation unless they are part of this personalized, goal-oriented, collaborative approach. And so that's what is really important for us to highlight. So I think, I hope that I've given you some kind of, an overview of how cognitive rehab is actually used in the broader concept of dementia rehabilitation. And I think, we have a long way to go, before we see that dementia rehabilitation becomes part of routine care. But I think, with this report, we are hoping that people can see that it is actually possible. it's not something that is done by the specialist only. We have families talking about how they actually devise the strategies of their own in the absence of, specialized rehab practitioners support. So I think this is where I should actually stop, because I think I went over time. My apologies, and I'm very happy to take some questions. So shall I stop my slides?
Thank you so much. Really inspiring. And I think that I've just loved listening about how it's a way of making the things that we all hold, those ideas of starting off with understanding the person, that's so key to person-centered care, and making it really concrete. It's just fantastic. So a couple of things that sort of flow on from that. And the first one is around the fact that you were doing this training with the people that were involved in this project. And that seems like it has real implications for how we are training our people who are going in, our nurses, our OTs, Orchidea's also raised our recreational therapists. This is really essential training for our health professionals to be getting, isn't it?
Yes, it is. Training is really important, and I think we haven't perfected. And I also have learned that the workforce composition in the community setting is quite different, even though they are the same professions, registered nurse and occupational therapist. I don't know well enough, to comment on the New Zealand context, but in Australia, when it comes to residential aged care homes, they don't usually have occupational therapists, employed. Some care homes have a physiotherapist, often working part-time, one physiotherapist looking after 150 residents. And so I think, the work with the allied health profession is quite limited. And so we often have to bring external, occupational therapists working with the registered nurse working in the care home. And also the way that, their level of understanding of rehabilitation, they all different. So you offer this training. So when we were doing our I-HARP in the community, we had the luxury of making specific rules, like, those clinicians must have, minimum two, desirably 5 years or more working with the people with dementia. And so we had very experienced nurses and OTs. Whereas in the care home, we couldn't actually make that because that's not real. And also, just because they've been working in the care home for a long time, that doesn't mean that they have sufficient dementia care expertise. So we had to implement this quite different ways of working with them. And I provided a lot more supervision over the period. So, for example, for the community, we had just a 5-day training. So the nurse and OT are trained together for 3 days. And then there is 1 day each for the nurse. We are going through the actual protocol, what OT does and what nurse does separately. But overall principles and strategies, they all learn together because they work together in the end. We did, for the residential care home, what we did was we spent 1 day all work, getting the same training. And then the nurse, I visited individual care home, and then I provided the training on site because it was really important that we relate to the residents that they provide care. We provided the online training for the OTs. But what we did was we made sure that we follow up multiple times. So for the community version, it was one-off training. And then they had their own case conference and so on. We had a refresher kind of training 1 hour for cognitive rehabilitation, twice, but that was it. But for this, the care home, I provided additional support as part of the case conference, and then direct supervision, and they seemed to work a lot better. So we made sure that it's not just person-centered for the client. We had to be person-centered also with the practitioners. I hope it makes sense.
That is such it's such an important thing, isn't it? That
Yeah.
we bring those same things into the way that we provide training. And you were able to create practitioners who went out and did individual
Yeah.
work with these clients. You weren't giving them a protocol of do the same thing with every person. So that was a huge thing to be able to
Yeah.
bring out that kind of expertise.
Yeah, so that's a really an interesting point, Susan, because we have a protocol, we have a case book for individual client or resident has their own case book, but then it has all the instructions, the assessment. The assessment takes quite a lot of time, but then once that's done, how they set goals, it's a blank page. But then we have instructions how they set goals with the person. So this is what we really had to visit again and again, how to set goals and strategies with the person, because you're not actually practicing that in your day to day. So, I have to say it's rare the practitioner picks up that, goal setting straight away. They had to go through the practice. And this is our next chapter of work that we want to do, that we want to bring technology so that the nurses and OTs, when they set goals, then there are ways for them to have more options so that less experienced clinician can actually use the technology to feel, more confident about the goals and strategies.
Because I think that, some people who have been listening, we've got a comment come through about that thing of goal setting is really tricky. Like
Yeah,
when it sounds simple,
yeah,
but as you're saying, it's not actually a familiar thing for the person with the lived
yeah,
experience to be
yeah,
coming up with this. And just,
that's right.
I don't know if you have any tips
Yeah,
about, things that you've found really helpful on the way through for us all to
yeah.
bear in mind, whatever our
We sometimes we don't even use the term goal because, what is your goal? If someone asks me, I would struggle, right? So, what do you enjoy most? What do you really want to do? And what are the difficulties that you have? You wish overcome those difficulties. And one of them is about this resident in the care home that, you know, he really likes going for a walk. The thing is, he can walk, but he has to wait for the care worker to come and help him wear his shoes, and he can't tie his shoes on his own. So sometimes we offer special shoes that he doesn't need to use the shoelaces, but other times that he wants to learn to use it. So that was what OT did, working with the person. So he doesn't have to wait for the care worker to help him to wear his shoes. Now he feels that's how he has that independence. He may still have, dependency on other areas. So we want to make sure that everything is unpacked. If this person wants to have a shower, now the person may wish to, wash their upper body themselves. So it's not the care worker going in and then they, well, let me help you with the shower and do everything. But the person may say, well, I want to do this part myself. So it's unpacking. What is it? What is it that makes the person feel independent? You have to find those points and then unpacking it. What we found difficult in the care home environment is that we often have people in their 90s and they say, I've done hard work all my life. I'm happy with someone else doing things for me. So you then find the different ways of helping, it's having sense of purpose and, feeling that they can do. It doesn't have to be everything. It can be one or two things. If finding the points, once you found that, and then you start thinking about how long would it take to make it perfect or near perfect, or the person feels that they're confident. So you then thinking about time frame. Is it once a week or twice a week? You also in the care home environment or in the community, you have to think about who is available. So if the person wants to go for a walk, then if the person can't walk by themselves, then you have to find someone to walk together. So it's taking that into account. So it's nothing that is a script and the recipe that you do this for everyone, because everyone is so different.
Oh, that's a beautiful last thought. And thank you so much for sharing with us today. And I'm just going to say that we've had a couple of comments that sort of echo some of the things Orchidia has been saying about what a great opportunity we have in terms of the availability of the recreational therapists in care homes.
Yeah.
And Elaine is just reinforcing that idea of the importance of a rehabilitation mindset, because that's really,
Yeah,
isn't it?
that's
It's
right.
about
Yeah.
going in with this mindset, and that physiotherapists and OTs and now, the nurses coming in with that awareness of the potential of everyone that they're working with.
Yeah.
It's such a powerful thing. So
If
thank
I
you
may, just
so
one
much.
comment.
Yeah.
Like what we found was that our lifestyle, coordinators, and often they have this, they often have very good relationship with residents. But what we found was that they not able to offer that individual. So when people with dementia are the ones often miss out on a lot of group activities. And so one of the service providers said they thought that they had a fantastic, lifestyle programs and all of that. And they didn't know how, limited those programs were until they've done this program. And the practitioners say, this is the first time I'm actually learning how to be person-centered, because they could see that step by step.
Yeah, I think we, because I am involved in education, I can just I have an itch for this kind of training to be everywhere. I think I think you've got such a lot to share. So thank you so much for your time today, and we really appreciate it. And I'm going to introduce our next speaker, Dr. Makarena Dudley now. And Makarena is a clinical psychologist. She's a neuropsychologist and an academic with the University of Auckland. And Makarena has just really changed the landscape for us in New Zealand with the work that she's done. She's led the team that has brought us the Mana cognitive tool, which is culturally appropriate for Māori. That's just changed what is available. And she's also led the development of the Māori adaptation of cognitive stimulation therapy. And she's going to be sharing that with us today. So we see the influence of Makarena across the motu, and we're delighted to have her back with us today. I hope that feels like you're coming home, Makarena. So thank you for sharing with us today.
Kia ora, Susan. Morena, and I'm going to try and share, and hopefully we'll go directly to yes, we're right here, to the slideshow. Okay, we're there. So, morena everyone, and ngā mihi kia koutou. It's lovely to be amongst friends and colleagues who I recognise on the little photos on the side there, the little screens on the side there. It's lovely to be amongst you again, and of course some new faces as well. So this morning, yes, I'm going to be talking about the modification of cognitive stimulation therapy for Māori. And so, as many of you will know, cognitive stimulation therapy is a non-pharmacological 7-week group activity, which is designed to slow down the progress of some of the symptoms of mate wari, particularly memory, and of course to enhance quality of life. So the design involves CST involves activities and exercises that encourage thinking, concentration, communication, and memory in the person with mate wari. It involves talking about day-to-day interests, past events and memories, and connecting them both to inform, what's happening in the world today. So it is a really good means or method or platform for orientating the person into the present time and space. So as you probably all are aware, it was developed by Amy Spector and her team. Amy actually developed this for her PhD, and it is a structured group treatment for people with mild to moderate dementia. Theoretical concepts of reality orientation, validation, and reminiscence therapy underpin this program. And we'll look at those a little bit closer later on. And it was CST was included and recommended in the World Alzheimer's Report in 2011. It has also been covered and approved by the Cochrane in a Cochrane review in 2012, and say they have a database which looks at systematic reviews of literature around health, and so very good a review out of the Cochrane database. And the CST is recommended amongst in the NICE guidelines, which is the National Institute for Health and Care Excellence in the UK. And so it's a part of the pathway for health providers in the UK. I was wondering, when did I start this journey? And I can't quite remember, but I think it could be 7 or 8 years ago when, so some of you, probably all of you, know of Gary Shung and Kathy Perry, who are very involved in cognitive stimulation therapy and have done dozens and dozens, I think, of workshops around the motu teaching this program. So they approached me 7 or 8 years ago about adapting this for Māori. And so I don't take easily to programs that are introduced into Aotearoa from overseas. I'm always very, very suspicious of them, and I've actually made a career of critiquing that kind of process. But so I was very skeptical at first. But what I did do was I looked at the program, and I love the concept of it. I thought, this sounds very much like a Māori thing. This is the platform in which the program was delivered was completely aligned with tikanga Māori and how we do things and how we practice things. So I delved into it a little bit deeper, and I could see that the content of the program was not suitable for Māori. But I thought, well, we can change that. But the actual concept and the way that the program is delivered really appealed to me. So I said to Gary and Kathy, yes, I'm interested, because, we don't have much out there in terms of fighting off this condition. And so anything that is, available and can be modified so that it is acceptable to Māori, I'm all for. I guess in a way I'm a little bit... well, I'm not biased, but in terms of where I come from, I do have a Western background in my education, but I also walk and tell Māori. So I think, I like to bring the best of two worlds together, and I think that's possibly, the best way forward for us. So was my thinking at the time. So I approached Tai Kake, who is another clinical psychologist and very steeped in Te Ao Māori and tikanga Māori, and he and I worked closely together in terms of the adaptation, and along with Gary and Kathy, who also had quite a lot of, because they have so much knowledge around CST, that it was wonderful to have them on board every step of the way. Just going back there, we used a formative method for adapting CST, and it had been used previously. I think it's in China and maybe in Hong Kong and maybe one of the other Asian countries. Anyway, this formative method is what we used, and that entailed generating knowledge and collaborating with stakeholders in the Māori community. Now, this was major for us because there's I never put a step forward unless I've consulted widely, particularly in this case as well with our kaumātua. Collaboration and with stakeholders was an enormous part of this whole process. Integrating generated information with theory and empirical and clinical knowledge. And that's, I guess, where I'm coming from, because I am a neuropsychologist by training. I have what we do instinctively, I guess, is incorporate theory and clinical and empirical knowledge into the work that we do. So you've got that kind of theoretical evidence base to support your mahi. We reviewed the culturally adapted CST intervention by stakeholders and of course, on each iteration after each collaboration, we would improve, hopefully, the version or the draft of the CST program. We tested the culturally adapted intervention in a pilot study, which was conducted down in Whakatane. And so we trained up some facilitators down there and got them to run the program. And we had some measures put in place, which I'll show you in a moment. And then we synthesized the feedback from that pilot study to come up with a final version of the CST, which I haven't actually mentioned at this stage. But so the name, obviously, we weren't going to call it cognitive stimulation therapy. So the term that we came up with, which means cognitive stimulation therapy, is Haumanu Whakaohooho Whakāro. And so that's the name of the CST program for Māori. So these are some of the demographics of the people who were involved in the pilot testing. So it was a mean age of 75.9. They were all female, eight of them. They were obviously all Māori. So their education was most were less than school C. No, a couple of them had less than school C education. 11 had secondary education, and there were 2 with tertiary education, which is great to see. So a few other factors down there, but so what we did was we administered the RUDAS, the Roland Universal Dementia Assessment Scale, I think it's called off the top of my head. There's so many of these acronyms for tools and measures that we use. But so that is a screening cognitive tool. So we administer that at baseline, at post, and at baseline, and then at post intervention. So, and this was the results of the assessment that we did. So the RUDAS, as you can see, had a statistical significance. Which was really cool. And also we administered the World Health Organization Quality of Life scale. Interestingly, it had each component, except the social component, had a statistical significance. The social component, I think we didn't get statistical a difference there, but I think because possibly the reason behind that is that our kaumātua rate highly in terms of their social connectedness anyway. So the opportunity for improvement is probably minimal, and I think that's probably what explains it. So we were delighted with the outcomes of our measures of that pilot study. So then we went to 4 different areas around the Motu. You can see mainly the North, completely the North Island, and met with several people who work in the area of delivering services for mate wareware. Really interesting. We had some interesting, could I say, lively discussions, kōrero, with many people, because many people have different versions on, Māori are very, and which is wonderful. Māori are very passionate about interventions, health interventions now, have their own ideas. So yeah, we did come across, we did have some really interesting conversations. I certainly have my preferences, but at the end of the day, as a researcher, that I need to put that aside, and what I need to do is produce the findings that are and the outcomes that suit most Māori. And we're never going to keep everybody happy. Different people have different ideas, or might think that this is not suitable for them, and that's kei te pai, that's fine. But what we came up with was a program that we feel fits well and was acceptable to most people that we consulted with. And it was, so there were 28 Māori health providers. We had non-government agencies and dementia services there, and they knew their stuff. They knew what they were talking about. They were very qualified in working with people with mate wareware. So it was very, very, very useful to get their feedback so that we could adjust the program where necessary. So this is the book, and some of you would have already seen it. The book, of the manual itself, which we went away on a weekend down in Rotorua at a very nice hotel, I have to say, motel, and the 4 of us, but Tai and I pretty much wrote a lot of the ideas or the framework of the manual, and then I went back home later on and kind of filled in all the gaps. So the manual is on one side, one side of it, you can read it in Te Reo Māori, and for those who want to read it in Te Reo Pākehā, then you can flip it over and the same version in Te Reo Pākehā. I know that a lot of our people do not speak the reo. I mean, I'm not a fluent speaker of the reo, and I only know bits and pieces. So I thought, it's really important that we cater to all of our people, not just those who are speakers of the reo. So hence the reason why we decided on that format. The photo on the front, just by the way, is, I don't know if any of you know of Dr. Waiora Port, who is just turned 93 and has been working and supporting not only mahi around mate wareware, but many other, neurological kind of diseases and conditions for many, many years. So that's her hand in tōtoko, which was actually gifted to her by Rangi Walker's family, for those of you who know who that is. Anyway, so some of the criteria that we came up with Haumanu Whakaohooho Whakāro is that there should be a group of a maximum of 7 in a group. I mean, it can get a little bit bigger. That's fine. There is a lot of flexibility in this program. When I say there's a lot of flexibility, to a certain extent, we also must be aware of standardization. And I think this is because I'm a neuropsychologist, and the standardization of any tool or any measure or any assessment that we utilize must be uniform, so that you're coming up with consistent quality outcomes. If you diverge too far away from the original program, then you start losing the quality, or you're compromising the evidence base of that program. So whilst I understand that was particularly working in a Māori environment where we don't have the resources that are available to others. But we do need to be flexible in order just to be able to run the program. So ideally, the sessions should be run twice a week. So this is an example. We find that in the north, Rena Schmidt and her team with at Te Hauoro or Ngāpui run several programs that have successfully run several programs up here in the north, and they're finding that actually the kaumata were so busy they're only available once a week. So the program is extended to 15 weeks, and that's kei te pai, so that's fine. How much you can be flexible, I don't know. But as I said, as a trained neuropsychologist, I pretty much stick to verbatim to how the original program or assessment tool was designed. Having said that, some of the words that we were forced to say to our patients when we were assessing for cognitive impairment or their cognitive abilities were just so ridiculous that I couldn't actually bring myself to say those particular lines to some of our Māori clients, because I thought, well, they're going to laugh at me if I say that. So I did, I was a little bit flexible in that respect, and you've just got to use your common sense and judgment. So in the original program, there is a maintenance program. Unfortunately, we have not got around to developing a maintenance program for Māori. It is something that is on the list to do, or to-do list next year. So what Rena and her team are finding in the north is that some of the kaumata love this program so much that they want to do the maintenance program. Of course, there isn't one available. So what they do is they repeat the program. And that's what we're going to have to do until we actually get cracking and produce a maintenance program. It has been validated in both community and residential care settings, not with... I don't actually remember it being validated in a residential care setting, so I'm going to have to retract that statement. I apologise and correct my slide there. It has definitely been validated in a community setting anyway. So it's been interesting. So there's been the development of virtual cognitive stimulation therapy Māori and individual cognitive stimulation therapy Māori. And I'm very interested in hearing more about those, particularly the individual ones. And it's apparently it's been proven to be very successful and effective. So so they talked about that at the Cognitive Stimulation Therapy conference, which was held in Canberra last week. Unfortunately, a terrible thing happened is that I got over there and I immediately became sick. So I spent the whole time in Canberra Hospital and missed the whole conference. So there was a lot of presentations that I wanted to listen to and learn about, and one of them was individual CST. So what I have got organised is I'm going to be meeting with Amy Spector early next week, and we're going to have a long Zoom meeting, and I will have lots of questions to ask her about, questions that are unique to Māori and some of the difficulties that we experience as Māori when implementing this program. So this, in terms of the facilitators, I guess this is where we had the most discussion was generated. So, but what we came up with was what was, as I indicated before, was most acceptable to most people. So it was decided that the lead facilitator must have whakapapa. Of course, everybody involved in the program must whakapapa. And have a good working knowledge of te reo Māori. And there's a really good reason for that is, and as you know, as the cognitive skills decline, the new memories start to fade and to die away and become lost, and long-term memories are more likely to be accessed. So the brain will access the pathways that lead to long-term memories. And many of those memories are in te reo Māori. And so we know that people who might have been taught the reo when they were young but got strapped for speaking the reo when they're 5 years old and never spoke it again. We know, we've heard many cases where the whānau reported, or dad or koro or nanny or whoever, all of a sudden started talking the reo, but they'd never heard him or her speak the reo before. So what they're doing is, so once you've learned a language, particularly if it's your first language, that never goes away. It is always lodged there in long-term memory. And so it's there. And what is happening is that now the pathways are being opened and that those memories are being accessed. So it's obviously the lead facilitator needs to be able to speak the reo in order to facilitate the session. The second facilitator should have whakapapa as well, and just some working knowledge of te reo Māori. And actually, most New Zealanders have a pretty good memory, school-based in terms of common, words, vernacular that we use in the reo in New Zealand in terms of te reo Māori. Now, this is the difficulty and one of the issues I want to talk to Amy Spector about is that facilitators should ideally be a registered health worker or have previous relevant experience, for example, working with people with dementia, similar clinical populations, and in delivering group interventions. Well, this is all very well, and this has come out of the manual for the original manual, but the problem with us, and that I've been finding, is that we don't actually have people with these types of qualifications. We have a lot of people who are, and I've noticed as I go around the country, and some of you will know that I visit, myself and Sir Richard Ford, we visit marae, and we talk about mate wareware and try and provide information about mate wareware, so to just develop awareness about this condition. We've noticed there's a growing army of health workers, Māori health workers working in this area. 7 or 8 years ago, there were very few people who worked in this area, but there is definitely a growing army. So they want to be trained in CST or Haumanu Whakaohooho Whakāro, which I'm really happy to do. But previously, we haven't really had the people that the clinical psychologists, the social workers, the occupational therapists, who are the people that were targeted, who this program were targeted in order to train up originally. Well, we just don't have enough of those people yet qualified. So one of my conversations with Amy is that, how do we circumvent that? And we've got people who are switched on but may not have the piece of paper, who have worked in the area of mate wareware for some time now. I think that's pretty important criteria to keep, because we know that there are special skills and special knowledge that is needed when working with people with mate wareware. So, I have been running workshops around the country. So unfortunately, I'm the only master trainer at the moment in this country, and that's something I'm very keen to change. So I'm able to train facilitators of the program, but I would really love somebody to step up and become a master trainer and help out with this kaupapa, because the interest in this program from our whānau is incredible, and which I'm really delighted, because I think it's a wonderful intervention. And even if parts of it are introduced into programs that are out there, or some of it is introduced, I think that it's still a real positive intervention to use. It may not have the efficacy as the original program, the complete package. It probably wouldn't have. We won't know, because the validation was conducted on the complete program. But I don't think that any aspects of this program being taught is going to. I think it's going to be a positive outcome anyway. So I'm all for it. So I think what we did was, one of the things that was decided through extensive collaboration and discussion and guidance was the principles in the original program we needed to change. And in fact, I don't even know what the order of the principles are in the original program now. I don't have it here with me. But first and foremost, of course, So I do know that in the original program, the first principle, and they were sort of numbered in order of importance, if you like. The first one was mental stimulation. That's the number one principle in CST, which I understand. But for Māori, the most important principle was the principle of person-centered. And so the principles, we swapped them around. They didn't change in any way, but the order more reflected the principles of tikanga Māori, the values of Te Ao Māori. So that's something that we worked on and came up with. So the programs, the order of the actual activities week by week, slightly changed. And what we did introduce was an extra session, and that is a whanaungatanga session where the whānau can come for the first session, ask pātai, ask questions about the program, learn about the program, and just get some sort of the feeling that, you know, their whānau member's going to be safe and okay coming to this program week by week. I was talking to a person in Australia who said that they hold they hire a room in a COSI kind of club, or one of the RSLs over there. And Judy, I think the Solomon, the wonderful work that you do, the Solomon whānau do, have done something like this. So they have the CST program running in one room, and nearby there's a cafe, so all the caregivers go and they get together and they talk about the issues that are confronting them, which I think is, you know, it's just wonderful. That's actually probably the perfect scenario. But so we included an extra activity, and so that took the sessions to 15 weeks. And there's a slight difference in order.
Makarena, I'm just going to give you a wee time warning.
Oh, okay. Oh, I need a warning. Okay. How much time have I got? Can't hear you, Susan.
Just a couple of minutes.
Oh, okay. All right. So, oh dear. Okay. So the theories, I'm really big on theory, probably because I'm a clinical psychologist. So validation therapy it's all about mana enhancing the person, making them feel heard, making them feel understood, and not being judged. So we validate the person. That underpins and underlines everything that we do in the program. Reality orientation is also important to the program, because, as you know, a lot of these people suffering with mate wari lose their sense of time and their sense of space. And so reality orientation is just bringing them back into reality in terms of where they are and what time they're in. Reminiscence therapy is something that we draw heavily on, and all that is drawing on old memories. And who doesn't like reminiscing about younger days and when I was young. So that is heavily drawn upon. You can look up reminiscence therapy, and there are ways of asking questions in terms of drawing out the best in terms of reminiscence therapy and validation therapy as well. So you don't ask questions whether they're right or wrong. You're more seeking opinions, and you're accepting of whatever they come up with. So we'll just have to leave it at that. So I don't know if these slides are going to be available. Hopefully I have put a little bit of description on what each therapy and what each theory involves. So reality orientation, or not so much, but reminiscence therapy calls on the different senses. It's a multi-sensory type of therapy where we access memories through smell, through looking at photos, through taste, so bringing food in. So the different sensory modalities are accessed in order to assist in accessing those long-term memories. So we talk about this as here, multisensory stimulation. And of course, as Māori, Wairuatanga, encompasses and underpins everything from go to woe in what we do. And that is really important for our whānau. And so that means starting with karakia and going through the processes that are familiar to us as Māori, starting with karakia, finishing with karakia, and so on. And anything that we do, we adhere to tikanga Māori, what is right for us. And you know what this manual is a guideline in that it can be adapted, it changed according to the iwi, the hapu, the rohi, where it's in. So you don't have to use the words that we've put in the manual. If it's not suitable for your rohi, change it and make it so that it is. There are in Kaitai, incredibly successful, thanks to Rena and her team. Has been run at 16 different sites in Tamaki Makaurau, Whangarei, and Christchurch and Hamilton as well. But I don't know how many because I go and train the facilitators and then off they go and run the programs. But there is more and more interest all the time. So I will travel. If you want me to come and do a workshop to train up facilitators, let me know. I think I've put my email address there. Yeah. And we can talk about that. And we have published on this modification of the CST program, and that is it there. And ko mutu tēnei presentation.
Oh, kia ora, Makarena. We actually had the privilege of hearing from Rena and the team about their project. And I think from both her and you, it's so exciting to have something that is effective and people love.
That's the best part. It's a win-win. It's effective and kaumātua. I love it. And I think that's what attracted us to it right from the beginning.
Kia ora. And we have a couple of messages from Hini Moana, who is actually in Australia, and I think it would be lovely for the two of you to connect more. But she's just saying, you know, how deeply it's resonated with her, and the ways of she'd love to keep talking with you about the ways that these kind of things uplift and really also in a culturally grounded way. And she just wants to say that you are a huge inspiration. Isn't that lovely?
Thank you.
Yeah. We've got another comment come through because, you know, you are just so inspiring about, are there thoughts about this in a Pacifica context? Is there a work stream that's...
That has been done. So so Kathy Perry presented on that. It's been modified for Pacifica and an Asian population in New Zealand. So that's already done and dusted. It's been out. It's out there in the public domain and it has been utilised. So once again, if you are interested in that, you can contact me at m.dudley@auckland.ac.nz and I will refer you on to Kathy. She would love to hear from you. And she has... I can't remember her name, but I met one of the facilitators down in who lives in Wellington, who is running the Pacifica program down there.
Oh, thank you so much, Makarena. And just to reassure people that we will be sending out the resources today, the video, the PowerPoints, the links to the articles that have been mentioned. So you'll be getting a little goodie bag that follows up from the hui. So I'm going to turn now to thank you again, Makarena. But our last speaker, the last speaker for the day is Dr. Matthew Croucher, and Matthew is such a champion and leader for those of us in the Dementia Māori world in Aotearoa, New Zealand. And Matthew is a psychiatrist of old age. He is the chair of the New Zealand Dementia Foundation, and he is the deputy chair of the Leadership and Advisory Group. And Matthew's going to be sharing with us a bit of an update on the potential roles of medication. So thank you very much, Matthew.
Thank you, Sue. I'm just so grateful for what Prof. Jun and Makarena have shared with us this morning too. You might wonder what on earth medication has got to do with our other topics today. And where this all started from, folks, was thinking about, would it be good to share some information about some of the positive treatments that add good things into the lives of people who are living with dementia and for their families and support people, rather than attention on the treatments and management strategies that we have that subtract bad things. So I just want to explain a little bit about where that comes from. This is a concept that has mostly come up in brain disease. So neurologists and psychiatrists and the nursing and allied health that support people with neurological and psych illness or brain disease. So that this is the concept that there are positive symptoms and negative symptoms of these conditions. And we don't mean the good and the bad symptoms. We mean positive symptoms are the things that you didn't used to have in your life that the illness has added on to you. And you don't want them, but they've been added on. Whereas the negative symptoms are the things that you used to have that the disease or the illness has taken away from you. All right, so that's what we mean by positive and negative. Let's think about arthritis. We don't actually tend to talk about positive and negative symptoms in arthritis, but there's enough of us in this digital room today that are living with arthritis, me included, with a touch of it, that I think you'll get it. So a positive symptom in arthritis is pain. You didn't used to have pain in those joints, but arthritis has added that onto your life. And an example of a negative symptom of arthritis is how stiff and slow to move you might feel first thing in the morning, right? You used to be able to just get up, get out of bed and move straight away, or get up out of a car after a 4-hour car journey and just move. But now you need 20 minutes to warm up, right? So that stiffness and slowness is an example of a negative symptom. We've taken away your ability to move, or the arthritis has done that. Now, the reason I'm telling you this is you can immediately think that there might be some treatments that work on positive symptoms. So they help you to reduce that positive symptom that you don't want, that you didn't used to have, and the disease has now added it. So an example of a reducing treatment for the pain of arthritis would be a painkiller. It reduces that positive symptom. But then what about the negative symptoms? That's going to be a harder one. We're going to need a treatment that boosts so that the negative symptom is mitigated in some way. So cognitive stimulation and cognitive rehabilitation both aim to boost something that some kind of deficit has arisen. What about medicine? Can medicine do that? So I want to introduce you to a group of medicines that have been around for 25 years now called cholinesterase inhibitors. Sometimes we call them the cognition enhancing drugs. And many of you will know, or those of you living with dementia yourselves may well have heard of these. So the main one in New Zealand is a medicine called donepezil, but there are 2 others available in New Zealand if donepezil doesn't suit you. And the next one is called rivastigmine, and the third one is called galantamine. It's not particularly important what these things are called, but just to know that there are these drugs, cognition-enhancing drugs. Well, that sounds so good, doesn't it? Why aren't we all on them? I'd quite like a cognition-enhancing drug, especially on a Friday afternoon. And of course, I do use one. I've had 2 cups of coffee already this morning. So, but these cognition-enhancing drugs for people living with dementia don't work for those of us that don't have a dementia illness. And I'm going to explain a little bit about why that is. So how these drugs were invented, and the invention of them started about 30 years ago. So we had 2 lines of information that were really interesting. So the first was that general doctors and nurses had observed that if you gave some people, particularly people with a mild dementia illness, or people that were at risk of a dementia illness but didn't have one yet, if you gave them a kind of drug called an anticholinergic drug, so something that takes this chemical in the brain called acetylcholine and stops its message getting through, that if you gave people those drugs, it could make their dementia worse or bring on what looked like a dementia where previously they didn't have one. So you stop that drug in a hurry. You might think, well, why are we giving these drugs to people anyway? Well, it's because they're useful for other things. So people with tremor in Parkinson's disease, these drugs can get rid of the tremor. That's great. People with an overactive bladder, these drugs can restore you to being continent in terms of how your bladder works. Great idea. But unfortunately, as a side effect, they can make people's memory and brain power worse. So that was the first thing that people noticed. And the scientists said, well, we better go out there and see if we can make a drug that boosts cholinergic function in the brain, and that might help people with dementia, right? So that was the first thing, first clue. The second clue was that scientists that were studying the brains of people who had died with dementia to work out what was the problem, what was going wrong, noticed that a significant portion of people, particularly people with Alzheimer's disease when they died, their brain circuits that use this chemical called acetylcholine were often very damaged and very damaged from early in the illness. So that was the second line of evidence that made folks think, well, if we could invent a tablet to boost this acetylcholine network in your mind, maybe that will help people living with dementia to do better in terms of their memory and brain power. So the search was on, and we already had a drug that did that. It's a very old-fashioned drug called physostigmine. So the researchers gave this drug to people with dementia to see what happened. And what happened is that all of the people with dementia vomited and felt really ill. They vomited a lot, but they said to the researchers, not only I feel sick, but I'm not going to forget what you've done to me. And they didn't. So it did boost memory and brain power, but made people vomit. So the search was then on to find better drugs that could boost the cholinergic symptom without this side effect of making people sick. And the first drug off the rank was something called tacrine, which is no longer available because it had other side effects that weren't good for folks. And what we've been left with is these three medicines, donepezil, rivastigmine, and galantamine. And in New Zealand, the main one is donepezil because that's the one that the government funds. So it's free for us all. And they funded it because it's a decent drug, works well most of the time, and most people don't get side effects. But because some people do get side effects, we need a backup, and the backup option is rivastigmine that the government will pay for if donepezil didn't work for you because it made you feel sick. You know, it still does happen. Now, I'm going to draw you a picture of what this all looks like. So we want to say, okay, well, that's great that that's all been invented, but what does that actually look like? So if I drew a graph, and I'm hoping that you can all see a graph, and if Sue can just nod to say that that's appearing, that would be good. Good. All right. So I want to imagine that here's a graph of brain power over time. So let's imagine here's 100% brain power, and here are the years going by. So that's time in years. You'll have to excuse my doctor's handwriting. What a dementia illness might do to us towards the end of our lives is it might affect us so that our memory and brain power are gradually going down. All right. Now, what we want to do is we want to invent a medicine that if we were to start it on this day, we're going to start our medicine down here. We want an improvement. So what happens when you start donepezil with someone? Well, in the best of all possible worlds, they'll have an improvement. But this medicine is not a cure for the dementia illness that's behind the scenes. It's a brain booster to help this negative symptom of I'm losing some cognitive abilities to improve. So eventually the disease will declare itself because it's still there, and a person on this medicine, their cognitive abilities will go down, but hopefully they'll always be better off than they would have been if they weren't on the medicine. Now, that is the best possible outcome of these medicines, right? So they're not miracle drugs, but they have given a boost. The average outcome is unfortunately not quite that good. So the average outcome is that I don't improve, but I stop getting worse. But I haven't cured the disease, so eventually it will take its course. So I'm still better off than I would have been, but not quite as better off as the person who had the best possible response. All right. So that's the average good result from these drugs. But some people get an amazing result. Now, what if they don't work at all? Well, you'll just stay on the bottom line. Okay, so that's the worst that can happen. Nothing happened. Now, let's think about this in a different way. It's kind of like we've set the clock back a bit, isn't it? How much have we set the clock back? Well, studies show us that the difference between the best possible and no effect is about, it's like we've set the clock back by 6 to 12 months. So it's not a huge amount, but let's just think about that a little bit because dementia illnesses are not illnesses that are striking people in their teenage years. These are illnesses that are striking people generally in the last decade or decades of their life. So 6 to 12 months in that setting is a significant percentage of my life that is left to me. If this drug was available for a brain disease that caused cognitive difficulties in teenagers and they were still going to live into their 80s or 90s, it would not be worthwhile at all. But because this is a drug that might boost cognitive function by a little bit and set the clock back a little bit for people that are in the last 10 to 20 years of their life, sometimes less, there is a significant difference. So the next thing that people would say is, well, hang on a minute, haven't you just postponed the inevitable? So that's not nothing, but is that really helping the person? Haven't you just postponed the inevitable? And the answer is no, because somewhere out here is the day that a person is going to leave us, is the day that a person is going to pass away and die. And these drugs do not change that day. So they don't make you live longer. So when they work, they have got for you a slightly better degree of cognitive function over the remainder of your life. Okay, so how much of an improvement are we actually talking about? So in the real world, and I've given several hundred people this medicine and personally followed them up to see what happens in more than 100 cases. And I've collected all these data and thought about them. So what happens? Well, the typical positive that you get back, and this is how the original scientists did their studies, is they said, well, let's give you a memory test and brain power test before you have the medicine, and then we'll do it again after, and we'll see if there's an improvement, or if we can't get an improvement, can we at least stabilize things for a while? Well, if you look at those tests, then and some of you will know that in New Zealand we typically use a test called the mini ACE these days, which is scored out of 30 and has questions like, draw a picture of a clock face and remember some words and so on. That not real life, but it still gives you a number out of 30. Well, a typical improvement on those tests is just a point or maybe two. That doesn't sound very worthwhile, does it? It might show me as a doctor that this drug has done something, yeah, because ordinarily, if I wait long enough, your test score on these tests won't go up by a point. It'll go down by a couple of points. If I wait long enough, about 3 or 4 months, it'll go down. So I'll be able to tell if the drug has done something, but is it really relevant? A medicine that can improve your score on a test like that by about a point, sometimes two. Well, the answer is that's not really what they're doing that's beneficial. Here's what families say. Families say when they work, I've got my old dad back. I've got my old wife back. I've got my old sister back. And I said, well, what do you mean? I mean, they're here. They were here all along, So what do you actually mean? And family members find it very difficult to put their finger on what they mean. But the unpacking it, it's things like previously, if we were having a conversation, he would answer the questions I ask, but he wouldn't ask me anything. And now he is. Or he's got a sense of humor back again. Or she's got her get up and go back again. Or she just seems more like herself again. So family don't say, oh, the memory's better. Or we went to the mall the other day and my husband could find his way from the your supermarket to the clothing shop. That's not what people say. They say, I've got my person back again, and that's priceless to them. What do people with dementia themselves say? Well, they often are not sure what to report. But when they have noticed a clear benefit, they tend to say things like, it's as if there was a fog and it has cleared in my head. I don't know how else to say it. So that's really worth it to people living with dementia. So when these medicines work, they do boost your score on a memory and brain power test. That's what I can notice. They produce a bit more spontaneity and get up and go in the person themselves. And family say, I've got my person back again. And the person themselves might say, my head feels clearer, as if a fog has lifted. Okay, so these are not earth-shattering improvements, but they are brain-boosting improvements that are worth something. And at the time these drugs were invented, we had nothing else medically that would produce this kind of benefit. So I want everyone that has one of the types of dementia that these medicines might help to have a go on them, or to be offered them, to choose whether they want to have a go or not, to give them the chance of the best possible boost, but at best, on average, a stabilization. I want everyone to have that opportunity, but I don't think they're miracle drugs. Now, every medicine has its problems, doesn't it? And these drugs do have side effects. And so, although most people don't get any side effects are possible and they're not rare. So, anytime we try one of these medicines, they must be a trial. Now, the final thing I wanted to say to you about those medicines is that, from my perspective, I'm more interested not in what they do for cognition, but in what they do for some of the other changes that crop up in dementia. And to do that, I want to introduce you to something called the neuropsychiatric inventory, because that's the piece of science that is the main way of looking at these. So here's a list of 12 things that can happen to some people that develop a dementia illness. So I might become more apathetic with less get up and go and less motivation. I might develop delusions, fixed false ideas that are out of keeping with my culture and my normal beliefs. I might develop hallucinations, and so on and so on and so on. So there's 12 different things that might happen. None of them are cognition. So none of them are memory and brain power. They're other things that my brain does. And a very interesting question was asked from the early 90s based on family members saying, I've got my old dad back. And the question was, might these so-called cognitive enhancing drugs be doing something to these? And the answer was yes, but not to all of them. The answer was that they improve the first three on average, but not the rest. So cognition enhancing drugs are strongly effective at improving apathy and can improve delusions and hallucinations a little bit, and probably don't have much effect on the rest. Now, that's important because apathy is the single most common behavioral change that people with dementia of any kind have to deal with. It doesn't mean that every person with dementia has a bit of it. It means that most people with dementia have some of it at some point in their journey. And apathy is very disabling because it affects my get up and go. So I can do something, but what I lack is the circuit that initiates me to do that thing that I can do is broken, so I don't. So if there's a medicine that can improve my apathy, that will help limit my disability, and that's what these medicines do. And I think you can see that might be why family are saying, I've got my old dad back, because that apathy symptom has been helped. So that's just a very quick romp through the cognition enhancing meds. You heard me drop the comment before that they don't help people with every type of dementia. They're better in some types than others. So they're better for the Alzheimer type of dementia. They're particularly good for dementia relating to Parkinson's disease, particularly dementia with Lewy bodies. And they can help some people with some types of vascular dementia. But in terms of the other common dementias in New Zealand, they don't tend to help people with alcohol-related dementia, and they don't tend to help people with any of the frontotemporal dementias. That's still quite a lot of people that they might help. But most people in New Zealand with dementia are in their 80s and 90s. Not obviously not everyone, and there's a very important group of people living with dementia in New Zealand who are in their 50s, maybe even younger. But by far, most people in New Zealand with dementia are in their 80s or 90s. And adding a drug to try and help them is a prospect that we have to think about very carefully, because what if I'm already on 10 drugs? Is another one really what I want to do right now? What about side effects, and interactions between them? So this is something that the doctor always has to think about, or the nurse prescriber always has to think about. Now, I want to give you a final few minutes on these fancy new drugs. They have names like lecanemab and donanemab. They all end with MAB. You read about them in New Zealand's most widely read medical journal, The Listener. And you've occasionally read about them in the Herald or the Press or Stuff. Researchers are very keen to promote them, and some of the Alzheimer's and dementia societies around the world, particularly in the UK, America, North America, and the States and Canada, those three English-speaking places, their Alzheimer's societies are pretty positive about these meds. But they are not available in New Zealand, except in a couple of research trials. What are we doing? Are we missing out? And I'm going to give you a very jaundiced view of these drugs. We're not missing out. They're incredibly expensive, extremely expensive. Not just the drug, but the whole array of specialized scans and staff that you need to deliver them safely. And honestly, in New Zealand, our services are so undeveloped, and I know I'm preaching to the converted here. If the Minister of Health rang me up this morning and said, Matthew, I really want to pump $100 million extra into dementia care every year, I would spend that money in 2 seconds flat. None of it would be on these drugs, and we'd make a huge difference in the life of people living with dementia and their families. I'm not saying that the drugs are completely and utterly useless, but they're just not that good. They're really, really dangerous, and they're incredibly expensive. So how good are they? Well, they're not nearly as good as donepezil, and donepezil isn't that good. So what these drugs probably do is there's a group of people who actually have Alzheimer's disease, but they haven't developed the dementia yet. It's coming, it's creeping up on them, and they've got Alzheimer's disease in their brain, but it hasn't got to the stage where they're developing memory and brain power symptoms enough to be diagnosed with a dementia yet. All right, so it's barely noticeable, but you can just notice it. And then you can do a special brain scan to prove that they've got Alzheimer's disease, and you give them one of these MABs. All right, so it's a very special group of people. A proportion of those people will be slowed in their progression to dementia, significantly slowed, by a year or two. That's significant, but it won't cure the disease. And the problem is, we don't know who that group of people is. We haven't got anything to identify the group of people in New Zealand that these drugs might slow it down for. And then how would you know if it's worked? Because quite a few people in that group don't go on to progress to dementia anyway. So there's just a whole nightmare of problems. Who these drugs are good for are people that live in extremely wealthy countries who themselves are wealthy enough to have extremely good health insurance, who live very close to a university hospital in a major city in Europe, America, or the UK, who want to try every single medical thing they can think of, even if the chance that it will give them a benefit is very low, and they're willing to accept the side effect of death as one of the possibilities. Now, I think that in New Zealand, we don't have those kind of people. So I think these drugs have been a major step forward in terms of research, and they are almost negligible in terms of their step forward in terms of clinical treatment. So don't worry that we're missing out. And the final word about them is that, do you remember I said that most people with dementia in New Zealand by far are in their 80s or 90s? Well, none of them have got pure Alzheimer's disease. Not one of them. They've got a mixture. And so why you'd think a drug like this would be helpful, the answer is it isn't. So I think it's really useful to know about those MABs, and I really, really hope that this helps us with the science enough that we can make a proper breakthrough in the next 10 years. But these drugs are not a clinical breakthrough; they're a research breakthrough, and I don't think they'll ever come to New Zealand except in research trials, and that doesn't bother me at all. They are available in Australia, but once again, only to people that can afford them. And I'm just anxious in New Zealand that we don't jump on bandwagons that will worsen the inequities between us. I'd much rather direct any new money towards funding things that work for everyone, and we've got plenty of those up our sleeve. We know what they are. They're not drugs. There are other ways of supporting people with dementia and their families. They're things like cognitive stimulation therapy and cognitive rehabilitation. And I want my money to be going towards those things and proper services for every family everywhere rather than these fancy pants drugs. So, ladies and gentlemen, my part of today was just to cue you into the small print, but important print about medical stuff that can boost our brain, that can help with the negative symptoms, the negative cognitive symptoms of dementia. And in that way, it's added a counterpoint to our CST and cognitive rehab discussions. And just from a practical point of view, to let you know that sometimes for people that would like to be able to take part in various aspects of cognitive rehab or participate well in a cognitive stimulation group, sometimes I say, well, let's try donepezil first, give you a boost, and then get you into one of those groups, and you might really fly. And that sounds like a good step forward. So thank you very much, and I really appreciate my fellow speakers and the chance to join them with those snippets today.
Thank you so much, Matthew. Now, I know that we're running very, very close to time, but just a couple of comments or questions. Virginia was just wondering about the role, positive and negative, about some of the other medications, like medications for blood pressure or cholesterol.
Okay, that's a great question. So we can think about most of those medicines as efforts to prevent dementia. And the data on them is growing to make us feel that one of the reasons that the rate of dementia is actually starting to fall in some of the more developed countries, we don't know about New Zealand, but there's no reason to think it isn't, just slightly fall, is because we've been paying good attention for the last 50 years to people's heart risk factors in the middle of their lives. And that this may be actually giving us some benefits now as we age. Because we know if we can stop smoking, if we are smoking, if we can stop drinking too much, if we're drinking too much, if we can lower our blood pressure if it's too high and raise it if it's too low, if we can lower our cholesterol if it's too high, and if we can make our blood less sticky with aspirin if it's too sticky, all of these things will protect us from heart attacks and strokes, but they probably all protect us from dementia as well. Now, once we have a dementia already, the evidence that these things will slow the progression of our dementia down is very limited, but medics think they are good things to do if you have heart disease or a vascular dementia. So they're targets, but they won't make you cleverer. They prevent things from getting worse at the same rate of knots. That's the idea.
Fantastic. Now we've got a couple of comments from our other speakers. Makarena just raises the really wonderful point that she and her research team have seen about the role of familiarity and the context in boosting people's functioning, and the way that they see this on the Marine, which is so familiar and safe, and the lift that gives to people.
Yeah. Yeah. So drugs are not the be all and end all, are they?
Yeah.
It's life is the main thing that helps our brain. Our brain is not primarily a machine. It's a tree. It's a living thing. At the end of every day, your brain is different from how it was at the beginning of every day. You've made new connections, you've grown things. Just in fact, because of this talk, your brain is different now than it was 2 hours ago. Hopefully, not in a bad way. So, uh, because of that, we shouldn't expect that mechanical tinkering will be as effective as good watering and sunshine and nurturing and careful pruning and, those things. But we all know as gardeners, don't we, that sometimes the right fertilizer will also help. And that's why medicine still may have a place.
Oh, thank you very much. And I know that we could just carry on with all our speakers to check in. But we've got people just saying how informative, how interesting it's been today. And just to echo that about what a valuable session it has been. And thank you to all our speakers. And I'm going to hand back to Teresa, who will just close for us.
Oh, kia ora, Susan, and thank you, Yun-Hee and Makarena and Matthew for a very stimulating discussion and presentations today. So if I will just close with karakia, kia whakairia te tapu, kia wā te ai te ara, kia tūruki whakataha ai, kia tūruki whakataha ai, haumia huia tae kia. Ka kite.